Hey everyone, Chris here from MedPrep2Go, and welcome to another episode of our USMLE Step 2 Questions podcast. In this episode, I'll be reading 3 more orthopedics questions from our online Qbank, and of course, you can read these questions and more at medprep2go.com. And with that being said, let's get started with question 1, Orthopedics 10. A 21-year-old man presents to the clinic for follow-up of a scaphoid waist fracture sustained 3 weeks ago. He was initially placed in a thumb spica splint. He is concerned about the long-term healing of the bone. The physician explains to him that the scaphoid is particularly vulnerable to healing complications due to its unique vascular anatomy. The majority of the blood supply to the scaphoid enters at the distal tubercle and the waist, traveling in a retrograde fashion to reach the more proximal portions. Based on this anatomical characteristic, a fracture at which of the following locations carries the highest risk for developing avascular necrosis? Is it A, distal pole, B, distal tubercle, C, proximal pole, D, scaphoid waist, or E, scaphotrapezial joint? And the correct answer is C, proximal pole. The scaphoid bone receives its blood supply primarily from the radial artery. Approximately 80% of the blood supply enters the scaphoid through the dorsal ridge near the waist and the distal tubercle. This blood then flows in a retrograde direction from the distal and middle portions of the bone towards the proximal pole. Because of this end artery supply with no significant collateral circulation from the proximal side, a fracture across the waist or proximal pole can sever the blood vessels, leaving the proximal fragment entirely ischemic. This leads to high incidence of avascular necrosis, AVN, and non-union in proximal pole fractures compared to distal ones. Answer choice A, distal pole, is incorrect. The distal pole is closer to the entry points of the arterial supply, meaning it maintains excellent perfusion even if a fracture occurs elsewhere. Answer choice B, distal tubercle, is incorrect. This is one of the primary entry points for the scaphoid's blood supply. Fractures here have an excellent prognosis for healing. Answer choice D, scaphoid waist, is incorrect. While waist fractures are common and do carry a risk of avascular necrosis, about 10 to 15%, the risk is significantly lower than that of the proximal pole, which is further downstream from the retrograde flow. Answer choice E, scaphotrapezial joint, is incorrect. This refers to a joint space, not a location on the scaphoid bone itself. While arthritis can occur here, it is not a fracture site associated with avascular necrosis of the scaphoid. Key learning point. The scaphoid bone has a retrograde blood supply provided by branches of the radial artery that enter distally. Consequently, the proximal pole is the most proximal portion of the bone, but the last to receive blood, making it the area at highest risk for avascular necrosis following a fracture. Question 2, Orthopedics 11. A 52-year-old man is brought to the emergency department with a 6-hour history of severe lower back pain and progressive leg weakness. He reports that the pain began after he attempted to lift a heavy crate. He also mentions that he leaked urine on his way to the hospital and feels as though he cannot fully empty his bladder. Past medical history is negative and he does not take any medications. Physical examination reveals 3 out of 5 strength in bilateral plantar flexion and knee extension. There is an absence of the Achilles tendon reflex bilaterally. Sensory testing reveals diminished sensation over the perineum and inner thighs. A digital rectal exam demonstrates significantly decreased anal sphincter tone. Which of the following is the most appropriate next step in management? Is it A, emergent MRI of the lumbosacral spine, B, intravenous dexamethasone, C, lumbar puncture and cerebrospinal fluid analysis, D, oral muscle relaxants and bed rest, or E, physical therapy evaluation? And the correct answer is A, emergent MRI of the lumbosacral spine. This patient is presenting with classic signs of cauda equina syndrome, CES, a surgical emergency caused by the compression of multiple lumbar and sacral nerve roots. The hallmarks of CES include severe back pain, bilateral lower extremity weakness, saddle anesthesia, meaning sensory loss over the perineum and inner thighs, and bladder or bowel dysfunction. Because CES is an emergency that requires surgical decompression, typically within 24 to 48 hours, to prevent permanent neurological deficits, the immediate next step is imaging with an emergent MRI to confirm the location and cause of the compression. Answer choice B, intravenous dexamethasone, is incorrect. While steroids are often used in cases of acute spinal cord compression, which occurs at the level of the spinal cord, ending at L1 to L2, their role in cauda equina syndrome which involves peripheral nerve roots, is not well established and does not take precedence over obtaining definitive imaging. Answer choice C, lumbar puncture and cerebrospinal fluid analysis, is incorrect. This would be appropriate for suspected inflammatory or infectious processes like Guillain-Barré syndrome. However, the acute onset following heavy lifting and presence of saddle anesthesia and urinary retention strongly point to a mechanical compression such as massive disc herniation. Answer choice D, oral muscle relaxants and bed rest, is incorrect. This is appropriate for simple mechanical low back pain or muscle strain. In the presence of red flag symptoms like urinary incontinence and saddle anesthesia, this approach likely would lead to permanent paralysis or bladder dysfunction. Answer choice E, physical therapy evaluation, is incorrect. Physical therapy is a staple of chronic back pain management, but is contraindicated in the acute phase of a surgical emergency like CES. Key learning point. Cauda-Equina syndrome is a clinical diagnosis characterized by saddle anesthesia, bladder or bowel dysfunction, and bilateral neurological deficits. It is most commonly caused by a massive midline disc herniation. The most appropriate next step is emergent MRI, followed by immediate surgical decompression to avoid permanent disability.
You always want the best for your family, and that means only Eggland's Best Eggs in your kitchen. Compared to ordinary eggs, Eggland's Best Eggs contain 6 times more vitamin D, 25% less saturated fat, more than double the omega-3s, 10 times more vitamin E, and more than double the vitamin B12. So why give your family less when they can have the best? Add Eggland's Best Superior Nutrition to your next grocery list. Better taste, better nutrition, better eggs.
Question 3, Orthopedics 12. A 28-year-old man presents to the clinic with a 6-month history of dull, aching pain in his lower back and buttocks. He states that the pain is the worst in the morning, lasting for about 2 hours and improves significantly after he goes for his morning run. He denies any specific trauma but notes that the stiffness has been progressively worsening, occasionally waking him up in the middle of the night. Past medical history is negative and vital signs are within normal limits. On physical examination, there is limited forward flexion of the lumbar spine and tenderness over the sacroiliac joints. A radiograph of the pelvis shows subchondral sclerosis and erosions at the sacroiliac joints. Which of the following is the most likely additional finding in this patient? Is it A, aortic regurgitation, B, episcleritis, C, increased chest expansion, D, presence of rheumatoid factor, or E, symmetric small joint arthritis? And the correct answer is A, aortic regurgitation. This patient's presentation of a young male with chronic inflammatory back pain that improves with exercise and is worse with rest, along with radiographic evidence of sacroiliitis, is highly suggestive of ankylosing spondylitis, or AS. AS is a chronic inflammatory disease of the axial skeleton. Extraaxial manifestations are common and frequently tested. Aortic regurgitation occurs due to inflammation of the aortic root and valve cusps, aoritis, which can lead to aortic root dilation. Other common extraaxial manifestations include uveitis, not episcleritis, apical pulmonary fibrosis, and restrictive lung disease. Answer choice B, episcleritis, is incorrect. While AS is strongly associated with eye inflammation, the classic association is acute anterior uveitis, also known as iritis, which presents with a painful red eye and photophobia. Episcleritis is more commonly associated with rheumatoid arthritis or inflammatory bowel disease. Answer choice C, increased chest expansion, is incorrect. AS leads to decreased chest expansion due to involvement of the costovertebral and costosternal joints. Monitoring chest expansion is a common way to track disease progression. Answer choice D, presence of rheumatoid factor, is incorrect. AS belongs to the group of seronegative spondyloarthropathies, meaning patients are typically negative for rheumatoid factor and antinuclear antibodies. They are, however, strongly associated with the HLA-B27 allele. Answer choice E, symmetric small joint arthritis, is incorrect. This is the hallmark of rheumatoid arthritis. AS typically involves the axial skeleton and may involve large peripheral joints like the hips or shoulders asymmetrically, but it does not typically present with the symmetric small joint involvement of the hands and feet. Key learning point. Ankylosing spondylitis is an inflammatory arthritis characterized by sacroiliitis and bamboo spine. Beyond the skeleton, it is associated with the A's. acute anterior uveitis, aortic regurgitation, apical fibrotic lung disease, and Achilles tendon enthesitis. And that will conclude this episode of our USMLE Step 2 Questions podcast. I hope you enjoyed it and found the information useful. Please be sure to follow us at MedPrep2Go on LinkedIn, Facebook, Instagram, and YouTube to stay up to date with our content. You can learn more and read other Step 2 questions at medprep2go.com. Happy studying! Hey everyone, Chris here from MedPrep2Go, and I want to take a quick break to announce that our first course is now live. Comprehensive Endocrinology is a video series with Dr. Raj Dasgupta that features 9 hours of content in 8 modules. This course is useful for learning endocrinology for internal medicine, family medicine, USMLE Step 3, and COMLEX Level 3. And this content is exclusive to the video series and won't be available on any of our podcasts. Keeping with our philosophy of making medical education affordable and accessible, this course is available for just $10 a month or $20 for a year. So check it out now and start learning at medprep2go.com. And stay tuned for more courses coming later this year.